send you a video so we can look at it later if you want. Okay, provider.sharefirst.com. Go to that website and you log in. Once you log in, see the searchlight. Okay, so you click on searchlight. So these are all the patients with risk and all that. Okay, so now if you go under searchlight, this is all the reports. Okay, so go to number 5, top 10 to 50 lists of high cost patients, right? So you go under that. So there are a few reports that are important. Let's start with gaps in care. So this is all the people that they have gaps in care that we need to fill, right? So for example, so when you go to the screen, obviously pick one doctor at a time, because if you pick all, that's too much. So I'm going to pick Dr. Rao. So these are the people who have Dr. Rao's gaps in care. Now, remember I told you that these people are, hold on, sorted by their highest risk. Actually, I'm wrong. These people are sorted by name. But frankly, these people here, hold on, where did that go? Okay, these people here, these people are sorted by the risk. Okay, they're not sorted by names. Okay, so for example, total gaps. So this patient, Mary Celestin, has 10 things that we need to fill the gaps on. Okay, so what you do, you click on the patient and you see what are the gaps. Okay, so these are the 10 gaps. They need to get a diabetes eye exam. So maybe they're referred, but basically we need to send them to an ophthalmologist. Okay. We need to do an A1C testing. So this patient didn't even get their labs done this year. Okay. We need to send them out to get their A1Cs. Medical attention to nephropathy. I'm thinking either that's the lab or sending them to a neurologist. Okay. Diabetes foot exam. Now, this is also sending them, sorry, this I think is sending them to a podiatrist. Yeah. Or we can do it because I have codes built in. So if they say, oh, I don't want to send them to podiatrist, that's fine. We can do it. Okay. Diabetes greater than 9. This you will know by using the CQMs in the office. Because see, Blue Cross will know that we sent them for an A1C. They won't know that whether it's greater than 9 or what the result is. This we tell based on, hold on, I'll show you. So when you're treating this patient, right? So if you go under CQM, which all the MAs know to do right now, we haven't had, sorry, I had a meeting with the Greenwell staff, but I did not have a meeting yet with
they're doing it.
staff.
They're doing it. I went in with them with Claudia and Thelma today to triage just to see, and they are doing it.
Good. So for example, here A1C greater than 9, between 7 to 9, less than 7, or not performed. This is how they will know. So if we pick 7 to 9, they will know that. Okay. And that's how this gap will be closed. Controlling high blood pressure, same thing. They will know this by if they go under CQM, and I think there is this hypertension or pre-hypertension. Yeah, sorry, hypertension, where it says less than 130 and less than 80, right? This is how they will know. So make sure we do that. Use of aspirin, same thing. If they have ischemic vascular disease and statin therapy, okay? So if they go under this and they say whether we're doing the statin therapy or not. Sorry, my bad. Okay, here, okay? So why they're not doing it, okay? Cervical cancer screening. This is from the order, okay? They have to order that. Body mass index screening. This will come from the BMI screening here, okay? Which is, where is that?
Weight.
You see it? Oh, this one right here, BMI screening, okay? So normal, 70 to 95 or whatever that is, okay? And tobacco use, again, this will come from, from CQMs too, okay? So out of like 10, there are 5 that the doctors can handle. There are 5 that the office need to handle. Okay.
Okay.
Now, so if you're calling this patient and asking them to bring back, you know which ones they have to do. Now, you don't have to every time look at this from the staff point of view because they're supposed to do this anyway. But for the physician point of view, you need to tell them, hey, you need to make sure that they order, send them to an ophthalmologist and send them to a podiatrist or whatever. Okay, so that's how you do it. So basically, every patient has a different thing. So you need to find those measures and tell them, okay, this patient, and you can see not all of them has 10. You know, but if you scroll down, this patient has only 4. So let's look at what Robin Tillman is doing. Just cervical cancer screening. That's it. Because body mass index will come from us, tobacco use comes from MA, controlling high blood pressure comes from MA. Just the cervical cancer screening has to come from the doctor. Okay. So if the doctor, if you already see that the doctor ordered it and the patient didn't get it, all you have to do is call the patient and say, hey, get this before December 31.
Okay.
So this is how you come to that list. So we went to Searchlight and we went to gaps in care. So job 1, let's work on these 50 patients. We have only 50 patients, and I would say at least if you can get the top 20 done before the end of the year, I mean, the more the better. But if you can get Dr. Rao's top 20 and Dr. Paul's top 20 and Dr. George's top 20, I think we will make a meaningful difference. Okay.
Great.
Okay. So everybody has like 50 here, just George and everybody. Okay. So just make sure that. Okay. So that's 1. So let's go back to the Searchlight. So where we went was Searchlight, and we went to number 5 and gaps in care. The other one is this high cost, high risk members with multiple indicators. Now, you can use this list to bump up your care plans. Okay. So this one, we only have 15 for Williams, 15 for George, right? But other people have only 1. So this is a great list that physicians can go by and create care plans. So let's suppose I'm picking Dr. Rao again. So Dr. Rao has 50 patients here. I mean, and all these patients are high risk, as you can see, you know, tons of risk here. And these are all sorted by risk. So Delson Murray, though her IB score is green, she is spending like a ton of money. Okay. Let's see why she's spending a ton of money. Click on her. Okay. When you click on her, and you can sit down with the doctors and see why, though she is green, why she's spending a ton of money, right? So guess what? She is doing okay. Lisinopril is fine, and all this is fine, but Stelara is a crazy expensive drug, and that's the reason why she's spending so much money on the system. So she spent $36,000, and I'm positive Stelara is causing majority of that. Okay.
Yep.
So let's look at this. So I clicked on that 84B, and guess what? She's using Stelara, and guess what? Our doctor is not doing this. It's actually done by Dr. Lakshan Norman, okay? But who is getting 10 lakhs? We are, okay? So we need to let the doctor know, and the doctor needs to see if, Lakshan Norman .1 is the right guy to refer. If he is the right guy to refer, then, we need to make sure, maybe the patient genuinely needs Stelara. So maybe, okay, fine, okay? But that's a call that we need to slowly look about, okay? Because out of all that money, they spent $17,000 this year just on one drug, okay?
Yeah.
Not good. So if you click on this, the Lisinopril, $3, okay? That's all it was spent, okay? So you see the discrepancy, right? So that's how we need to dig into the data sometimes and see what's going on, okay? And you can show this to the doctors too and say, okay, this is where they've been spending much money. Okay. Now, guys, you will be like, Chris, this is a lot of digging. You won't be doing this every day. Okay. You run these reports once every quarter and pick the top 25 candidates and work on that. Okay. Between what you're doing. Now, as I said, and again, not all these physicians. Marlene, you have 2 doctors mainly, and Regine, you have 3 doctors, Dr. George, Dr. Williams, and Dr. Wooden. Yeah, Dr. Wooden. Okay. So Dr. Francis is part-time. Go ahead.
Chris, if Dr. Burwa has a patient, can we enroll him under one of the other doctors here?
No, I wouldn't even touch them.
Okay.
Okay, because yeah, he's out of the thing. Unless he gets a lot more patients, I'm not going to enroll him.
Okay.
Okay, so let's talk about this list. See this pharmacy PM? You see a check mark? These are the people who are spending a ton on medications. Okay. Overall, this person is spending money. Overall, this person is spending money, but not much on medication. I mean, I'm just trying to show you how you can narrow this thing a little bit. So this patient, Charles Hallett, overall is spending money, but is not spending too much money on medication, right? So why is he on the list? Because he has a ton of gaps in care, and his disease instability is much high. So because he has CAD, coronary artery disease, maybe he's going a lot of times to the hospital and all that stuff, right? So if you click on his name, Charles Hallett, we will get some more details. Let's look what's going on with him. So he spent, as you can see, almost $100,000. Okay.
Probably in the hospital around April.
Exactly. So he's, and these are his results of whatever, cholesterol and all that. Okay. So, wow, it looks like they do have the details of their A1Cs and all that too.
She was saying that if the patient goes to LabCorp, they do get the information, but if they go to any other lab, they don't.
They don't? Okay. Oh, so that's good then. In one way, actually, that's good. Okay. So then you can look at the patient's, clinical summary, assessment and plan, what's going on with them. Let's look at their clinical summary, kind of an idea of what's going on, assessment and plan. So you can actually, the doctors can sit down and review a lot of data from here and then tell you whether you want them to bring them in or not. Okay. So we have all the data here. And again, do this for 25 patients, not all, the top 25. You can look at it. You don't have to involve the physician because you know the patient sometimes. Yeah. Mainly Regine, you know the patient. So pick the top 25 guys. And Marlene, initially you may have to sit down with the doctor. And also, Marlene, has good doctors. Dr. Paul will sit down, Dr. Rao will sit down. And Regine, I think your physicians are a little on the edge. So Dr. George may not have time or Dr. Williams may not be happy, but you have the strength because you know your patients. So if you want to bring them in and, see however you want to do this. Now, see the CCM, Care Coordination Program. I'm not sure whether they're saying this patient is eligible for the CCM or whether they already have it. So just look at it and you can talk to them, to your nurse and say, okay, are they already in CCM or are they telling us that we recommend it or they are good for CCM, okay? If they are not done and they're saying recommended, that's great. You know what? You can start with these people, highlight those 6 people for Dr. Rao and just push them for CCM, okay? So you can look here. So this patient, for example, Delanton Murray, as I was telling you, high patient, spending high money on this, but they don't have multiple comorbidities, but this patient does. Teresa Dickerson has multiple issues going on. None of these patients except this guy, Charlie Dubois, is spending too much money on hospital usage. But all these people are spending too much money on prescriptions. So basically, you're getting an idea. That's what I'm saying. So if you sit down with the doctor, print this, and they say, what's going on with these guys? You can tell them, okay, these people have multiple issues. We should put them on CCM. But as you can see, everybody has gaps in care. That's what we need to reduce, okay? So this month, if for us, homework for next week, I know this week is already ending, is log into the site, find the top 25 patients for your 2 or 3 doctors, print them out, talk to them, okay? And bring the patients in, take their gaps of care, and, work on that, okay? And with that, we will build both of these other issues. We will build the care plan automatically by doing this, and we will already obviously build the engagement because the more care plans you have, the more times we'll be calling the nurse and the doctors will be talking and all that stuff, right? So that's how I'm actually surprised and happy that Blue Cross has so much data on the patients and they're giving us the names and everything, which is good. So let's use that data and try to build on that. Okay.
Okay.
Any questions on this?
No, it's pretty simple.
Okay. Regine?
No, sir.